Our next presenter is a man who knows global health and the WHO from inside out. And remember, the people who've come from inside are some of the most fearless freedom fighters working for your best interests. Dr. David Bell, is now a senior scholar at Brownstone Institute. He's a public health physician and biotech consultant in global health. He is the former medical officer and scientist at the World Health Organization. He was the program head for malaria and febrile diseases at the Foundation for Innovative New Diagnostics in Geneva, Switzerland, and director of global health technologies at Intellectual Ventures Global Good Fund in Bellevue, Washington. His presentation, Why Policymakers should reject WHO's pandemic proposals. Dr. Bell, it's a pleasure to have you with us this evening.
Thank you, Catherine. I think, I'd like to go very briefly through the history of the WHO and its implications for what's happening now with pandemic preparedness. It's important to understand how the WHO has changed over 75 years. So it was started in 1946 in the aftermath of fascism from World War II, and in the era of decolonization, it reflected that it was set up with the World Health Assembly governing it, one nation, one vote. It was based on core contributions from countries where countries gave according to their GDP. The WHO would decide from a technical point of view how to use that. And it embraced a fairly holistic view of health, physical, mental, and social well-being. So this was sort of continued for several decades. The Alma Ata Declaration of 1978 emphasized the importance of primary care, community empowerment in the provision of healthcare, and in the importance of people and communities making their own decisions. So it was a very decentralized, horizontal view of healthcare. So this changed, and has clearly changed now. We're dealing with a different organization. So Wolfgang showed this budget. So this is the current budget of the WHO, and the assessed contributions, it was a core budget, is the sort of the green at the top there, and voluntary contributions specified and thematic make up about 80% of the budget. And this is important because specified contributions are contributions that are provided for a specific project in a specific place. They're very directed. So the WHO, for 80% of its budget now, is doing what its funders tell it to do and fund it to do, not what it necessarily considers to be the appropriate way to impact public health. And this money comes from a few countries, but increasingly over the last 2 decades also from private sources. So you can see the second largest funder of WHO is now private. Gavi, number 5, is also very heavily funded by private interests, including pharma interests. And as you go down, you get other private funders. So it's an organization that does what its funders ask it to or tell it to do and fund it to do, and is significantly privately funded and influenced. So in this context, COVID came along, and just before COVID, late 2019, the WHO produced this guideline for pandemic influenza. And it specifically said, don't do contact tracing in an established pandemic, don't quarantine well-exposed individuals, do not conduct entry-exit screening, do not conduct border closures. And it envisioned that closure of unemployment workplaces may be for 7 or 10 days. And this is very clear. This is an evidence-based guideline. This is orthodox public health and what is shown. And the reason for this is because if you do these measures, you cause extreme poverty, particularly in low-income countries. You disrupt economies. So we knew very early on in COVID that this is the age distribution from China, published in Lancet in March 2020, that it almost exclusively affected old people with severe disease, young people, those working, paying taxes, etc., students were very, very rarely affected by COVID, and this didn't change. The population pyramid of China is on the left. Europe is very similar. On the right is sub-Saharan Africa. And you can see the top line is 75 years, over which almost all COVID deaths occur. There's almost no one in Africa. It's less than 1% in that age group. Half of sub-Saharan Africa is under 20 years of age. So you can see that the African population is intrinsically not at risk of severe COVID. In this context, the figures show what we expected. So you can see there the mortality per million people from attributed to COVID. The top two lines are the USA and the United Kingdom. And African countries, and there's 6 there, typical African countries, barely get above the baseline. So very, very little death in Africa. On the top, you can see in life years lost. We have malaria, TB, and HIV, which are the endemic diseases that cause a lot of loss of life there. And COVID has hardly had an impact. So despite that, the lockdown measures that were introduced for the first time in wealthier countries with older populations were also pushed by WHO in Africa with the expected outcomes that WHO had also predicted earlier. So we see a similar situation in South Asia where the UNICEF estimates about 250,000 children died just in the first 9 months of COVID in 6 South Asian countries from the lockdowns, not from COVID. We have 100 million people extra in poverty, 10 million girls forced into child marriage over the next 10 years because of closure of schools. And the World Bank notes that this is pushing particularly the poorest countries into extreme poverty. So this was predicted. This is what happened. Despite this, the mass WHO pushed with its partners this mass vaccination program for COVID. So on the slogan that you would have heard, no one is safe unless everyone is safe, which if you're not safe after you've been vaccinated, it means the vaccine doesn't work. So it's a very strange slogan. It illustrates the sort of thought processes behind this. They did this in the knowledge that most of the African population was intrinsically safe because of age. Also, that their own study showed that 2/3 of the population before Omicron in Africa had antibodies to COVID, to SARS-CoV-2. So they also, it had already been through. CDC has shown that post-infection immunity is as good as a vaccine. So there's no possible public health benefit for almost anyone from this vaccine in Africa. Despite this, billions of dollars have been spent on this for low-income countries. Over $7.5 billion so far on COVAX. In contrast, the entire WHO budget for a year is $3.5 billion, less than half that. We spend $3 billion on malaria globally, which kills over 500,000 children every year. So not only is there no public health basis, but it is hugely harmful in diversion of resources for more important burdens. So Africans, low-income people elsewhere don't benefit, but it is clear who has benefit, and the people who particularly push this this agenda and who are implicated in the private funding and corporate funding to WHO have made hundreds of billions of dollars out of this. So we can draw our conclusions from that. So going forward from COVID, there's not a sort of soul searching. There's a push to make this a much more permanent way of doing public health. So this is again from the same influencer document of WHO. It shows that in WHO's parlance, since the Spanish flu, where most people died due to lack of antibiotics from secondary infections, there's been just 2 or 3. Swine flu killed less than we normally see dying from flu each year. The Asian flu, Hong Kong flu in 57, 58, 68, 69 killed less than the number of people that die from tuberculosis every year. So for the last century, pandemics have been a very small health burden relatively. Yet we are building this pandemic industry that is costing more than any other public health program. It's going to surveil for variants. It will find them because this is nature. You always get viral variants. It will declare risk. It will lock down and restrict, as we've seen from COVID. It will offer mass vaccination as a way out of that, and then it will surveil for more variants. And this will be funded by billions of dollars of taxpayers' money. They're estimating $10.5 billion in additional money per year. And the big winners will be those who make the vaccines and benefit from control of populations. which is essentially the private sector. And this is likely to happen because it's creating thousands of jobs. So there's thousands of salaries, thousands of self-interested people who will be pushing this agenda. So there are two instruments that the WHO is using to push this. There are a number of other initiatives, but two main instruments that people have heard about: the International Health Regulations amendments. So this is really the teeth of the agenda. The IHR has force under international law. Most of it is now just recommendations. And there's a treaty, which they're calling an accord, which will provide the sort of financing and governing for this pandemic agenda process. So the draft amendments to the IHR, they expand the definition of pandemics and health emergencies to include potential for harm, not actual harm. So they just have to find a viral variant that could theoretically harm humans and cross borders. They don't need to find actual harm to humans. It'll change the definition. It'll change the recommendations from non-binding to mandatory, because countries who sign up to this or don't reject it undertake to follow the recommendations. The Director General will have sole and independent ability to declare pandemics, as we saw during monkeypox. There's an extensive surveillance process being set up, and states will be assessed on this. The countries, the WHO will be able to share country data without consent, which is new. They'll have control over certain resources, including intellectual property and manufacturing capacity of any product related to health well-being, related to human well-being as it's currently drafted. And they'll promote censorship so that people can't openly oppose this process. So the current recommendations they're very clear. They include travel restrictions, confinement, isolation of individuals, mandatory vaccinations, mandatory medical examinations. So this is the sort of thing that we saw in COVID that will become mandatory rather than recommendations. The treaty essentially sets up the governance and supply network for this whole structure. It asks countries to give 5% of their health budgets to health emergencies, which we saw a very low health burden in most low and middle income countries, also in high income countries where NCDs are a bigger issue. They're a very, very small part of the overall health need. And it'll expand the scope to include One Health. So not only is it just threats to health, but those threats expand to anything in the biosphere or in human behavior that could potentially impact on one of those parts of health, which is both physical, mental, and social well-being. So this is really giving control over anything related to human life or well-being to the WHO to declare as an emergency, and then take control over national health systems or aspects of national health systems. So the IHR amendments, there's next week we'll have the World Health Assembly and they'll be discussing these, but they're expected to be put to a formal vote in 2024, a year from now. They'll just need a majority of those in the room, countries in the room. There'll then be a 10-month rejection period. Countries have to actually reject them. And they'll come into force a couple of months later for the country. And so if a country doesn't actively reject these, it will essentially, under international law, it will have undertaken to follow the instructions of the Director General. So the treaty has a similar timeline. It will need a 2/3 vote because it's a new process. It'll require 30 countries to ratify and then come into force a month later on those countries who ratified it. So to summarize, pandemics are rare events. They can happen, they're rare, and over the last century, the burdens are very low. We expect this because we have antibiotics, we have other modern medical care. WHO's record shown in COVID is essentially incompetent, but worse than incompetent. It has massively exacerbated harm and increased poverty, which will have very severe long-term effects on life expectancy across all countries, but particularly low and middle income countries, which is most of the global population, and the population that WHO is supposed to be primarily addressing, where other health burdens are most severe. Any rational approach to pandemics would include improving immune immunity, for instance. We've seen from nature that vitamin D, the impact of that on reducing severe COVID, which is the same with other respiratory viral infections. And it would recognize national and local differences rather than having this centralized one-size-fits-all response plastered across all populations, which is clearly inappropriate. Health policy going forward to prevent what has happened in COVID, it must be freed from conflict of interest. And this is going to take, it is difficult to see whether this can be done in WHO now that the control and the influence of private sector is so strong. But clearly we need international health bodies that are can only give advice to countries and that are completely clear of private conflict of interest from those who would benefit from its decisions in a financial way. And essentially, the way we are going, we are setting up a situation where life has become an emergency, nature has become an emergency. So we're putting ourselves in a position where we'll be under constant this sort of authoritarian health state. So to prevent this, particularly legislators this is an issue for democracy, as Wolfgang said. We need to preserve democracy. We have predatory corporations and private greed that are using public health, corrupting public health to take over our democracies and our societies. And we need to urgently move on this to prevent this from happening. Thank you.